Hi. Um, I guess I can begin the lecture now. Um, First of all, I wanted to thank Dr. Tony Golan and Dr. Blair Wiley for inviting me to give this lecture. Thank you all so much to all of you for joining as well. I know it's 5 p.m. and I do understand that most of us are just finishing up our day on labor and delivery clinics and ORs. So I appreciate all of you making time for this. I'm Megha Gupta. I'm one of the maternal-fetal medicine physicians at VIDMC. I graduated from maternal-fetal medicine fellowship in 2018 from Cedars-Sinai and UCLA. And then I've previously been at UT Houston and at Yale before joining VIDMC in November of 2021. The topic that I will give a lecture on today is updates on management of chronic hypertension pregnancy. Chronic hypertension is a very broad topic, as most of you know. However, given our limited time, I would like to keep the focus on just updates on management of chronic hypertension. I do tend to speak fast, so if something doesn't make sense or if you have questions, just please drop that in the Q&A box. And I'll be sure to get to it before the end of the presentation. So without further delay, I do not have any relevant financial disclosures. In terms of my outline for this lecture, we'll first review the classification of hypertensive disorders in pregnancy. Then focusing on chronic hypertension, we'll discuss its epidemiology, definition, how to take proper blood pressure measurements. We'll also discuss some of the controversies regarding management of chronic hypertension pregnancy. And then we'll turn our focus onto the CHAP trial, discuss its objective, hypotheses, inclusion, exclusion criteria, and its findings, as well as the implications of those findings. And lastly, we'll discuss the updated SMFM and ACOG guidelines, specifically their practice advisories, practice bulletins, and committee opinions focusing on management of chronic hypertension in pregnancy. So in terms of classification, let me minimize this part. In terms of classification of hypertensive disorders in pregnancy, there's chronic hypertension and gestational hypertension. Exacerbation of these conditions results in preeclampsia. Preeclampsia can be without severe features or with severe features. If preeclampsia develops in a patient with history of chronic hypertension, then it is called superimposed preeclampsia. And that can also be without severe features and with severe features. Finally, there's eclampsia, HELP syndrome, and thrombotic microangiopathies such as TTP and pregnancy-associated hemolytic uremic syndrome. The challenge is in distinguishing these classifications from one another, which in turn dictates management of our patients, including medication dosing, laboratory evaluation, requirement for hospital admission, antenatal surveillance, as well as the timing of delivery. Now, specifically turning our focus onto chronic hypertension. In United States, chronic hypertension develops in 2% or more percent of pregnancies, and it's a significant contributor to maternal, fetal, and neonatal morbidity and mortality. This condition disproportionately affects Black patients and is associated with 3 to 5 times increased risk of preeclampsia, abruption, cesarean birth, postpartum hemorrhage, gestational diabetes, preterm birth, anomalies such as heart defects, hypospadias, esophageal atresia, as well as growth abnormalities and perinatal death. The condition is also associated with 5 to 10 times increased risk of maternal death, heart failure, stroke, pulmonary edema, and acute kidney injury. It is important to note, though, the absolute risk of mortality and major maternal morbidity is low, and most women with mild chronic hypertension will have uncomplicated pregnancies. It's only in cases of severe uncontrolled hypertension does the risk of maternal complications markedly increase. Now, traditionally, the criteria for diagnosis of hypertension in pregnancy requires systolic blood pressure that's greater than or equal to 140 millimeters mercury, or a diastolic blood pressure of 90 or greater, or both. Mild hypertension is defined as blood pressures between 140 and 159 over 90 to 109. And mild chronic hypertension affects about 70 to 80% pregnant patients with chronic hypertension. Severe hypertension is defined as blood pressures that are greater than 160 over 110. In general, it is recommended that a diagnosis of hypertension requires at least 2 determinations, at least 4 hours apart. Although on occasion, and especially when faced with severe hypertension, the diagnosis can be confirmed within a shorter interval, even minutes, to facilitate timely delivery. Chronic hypertension is defined as hypertension diagnosed or present before the pregnancy or detected before 20 weeks gestation. Hypertension that is diagnosed for the first time during pregnancy and that does not resolve in the typical postpartum period, typically about 12 weeks, is also classified as chronic hypertension. Now, this is the diagnostic criteria for chronic hypertension outside of pregnancy. So in 2017, the American College of Cardiology and the American Heart Association changed the criteria for diagnosing hypertension in non-pregnant adults. And these recommendations include classifying blood pressure into 4 categories: normal, elevated, stage 1, and stage 2 hypertension. These changes were made to assist in clinical and public health decision-making, and they reflect data that suggests that long-term cardiovascular risk is modifiable, even in the elevated and stage 1 hypertension ranges. More importantly, the recommendation suggested beginning treatment in non-pregnant adults with stage 1 hypertension. So as obstetricians, we may see an increase in patients classified as being hypertensive based on these ACC and AHA definitions. And then questions arise whether these patients, if they have been started on medication outside of pregnancy, do we still continue those medications during the pregnancy? Is it safe to do so? Is it evidence-based? And should we offer these patients antenatal surveillance and discuss an earlier timing of delivery? Now, antihypertensive treatment, we know it's standard of care for non-pregnant patients with non-severe hypertension. That is, again, stage 1 and stage 2 hypertension outside of pregnancy. But treatment of non-severe hypertension during pregnancy is controversial for several reasons. One reason is that while antihypertensive treatment during pregnancy reduces the frequency of severe hypertension, that's, again, blood pressures greater than 160 over 110, it has not been shown to improve maternal, fetal, or neonatal outcomes. And secondly, antihypertensive treatment during the pregnancy has previously, in observational and retrospective studies, has been associated with an increased risk of small for gestational age birth weight. So for these reasons, treatment recommendations for pregnant patients with chronic hypertension vary among international organizations, as you can see here. So we have ACOG, which is from the US, then CHAP, that's International Society for a Study of Hypertension in Pregnancy. Queensland is from England. Canada. SOMANS is Society of Obstetric Medicine of Australia and New Zealand. Then we see Brazil, Germany. NICE is National Institute of Health and Care Excellence. And then finally, ESC, ESH is European Society of Cardiology, European Society of Hypertension. So these variations that you see of when treatment is recommended to be initiated, these variations arise from limited evidence to drive clinical practice and largely reflect the reality that many aspects of these guidelines arise from expert opinion rather than high quality evidence. So in summary, while there is consensus to treat pregnant women with severe hypertension, for women with mild chronic hypertension, again, that's less than 160 over 110, it is unclear whether to withhold antihypertensive medication until the increase in blood pressure is severe, or to continue the patient's previously established therapy. So born out of these considerations is the CHAP trial, treatment for mild chronic hypertension in pregnancy. So this was a multi-center, open label, not blinded, randomized controlled trial with the objective to evaluate the benefits and safety of antihypertensive therapy in patients with mild chronic hypertension during pregnancy. The hypothesis was that with blood pressure goal of less than 140/90, there would be a lower incidence of adverse outcomes. And we'll discuss what these outcomes were in the study in subsequent slides. The inclusion criteria was viable singleton pregnancy less than 23 weeks and diagnosis of new or known chronic hypertension. Their patients were excluded if there was evidence of severe hypertension, known secondary hypertension, multiple gestation, pre-specified high-risk coexisting illnesses that warrant treatment at a lower blood pressure level. This mainly included patients who had diabetes diagnosed before 10 years of age or over 20 years duration, diabetes that was complicated by retinopathy, nephropathy, heart disease, as well as transplant history. It also included patients with cardiac disorders such as cardiomyopathy, angina, coronary artery disease, history of stroke, patients with sickle cell disease. And then other exclusion criteria included known fetal anomaly, fetal demise, suspected growth restriction, membrane rupture, planned termination prior to randomization, contraindications to any of the first-line antihypertensive drugs, and then finally patient and provider refusal. So once patients were screened and considered eligible and consented for participation, they underwent randomization. They were randomized to an active treatment group where treatment was initiated to maintain blood pressure goal less than 140/90 versus the control group in which antihypertensive therapy was withheld unless the blood pressure was greater than or equal to 160/105. Either first-line medication, that's labetalol or nifedipine extended release, was initiated based on patients' medical history, patients' past experience with antihypertensive medications, and provider preference or expertise. In rare instances, though, patients and providers preferred a medication of choice other than labetalol or nifedipine extended release. And this was allowed and patients were still considered eligible for participation. The other medications were amlodipine or methyldopa. For these patients, if the medication was needed, doses were escalated as per protocol to maximum tolerated dose before initiating second-line medication, dosing for which was then also escalated as per protocol before initiating third-line medication. In terms of follow-up, these patients had clinic visits during which patients were asked about their adherence to blood pressure medication regimen before any dose adjustments were made. Pill counts were also performed at the time of each refill, and other assessments included frequency of clinic visits, ultrasound and fetal surveillance to determine the timing of delivery. And these were all performed according to usual practices at each trial site. Patients were followed up until 6 weeks after birth. Now, just briefly, how blood pressure assessments were performed. At each visit, blood pressure assessments were standardized at all sites. So briefly, the blood pressure levels that met the criteria were documented on repeat readings, only after the patient had rested at least 5 minutes, preferably for 10 minutes or more. No caffeine or tobacco should have been used for at least 30 minutes prior to measurement because these can temporarily elevate blood pressure. Patient should have been sitting upright comfortably with back straight, supported, feet flat on the floor, uncrossed, arm resting with palm turned up. and then an appropriately sized cuff, which could be automated or manual, positioned at the level of the heart. The lower edge of the cuff should have been about 1 inch above the crease of the inner aspect of the elbow, and the cuff should have been wrapped snugly and secured firmly. And this is all because if there's a blood pressure cuff that is too small, it would result in an overestimation of the actual blood pressure. So can an unsupported back, crossed legs, or unsupported arm. This is different from when blood pressures are measured, in the hospital if a patient is in a recumbent position. If a blood pressure must be taken in a recumbent position, the patient should be placed in left lateral decubitus position, and the cuff should be placed at the level of the right atrium. So in the CHAP trial, the primary outcome was a composite of preeclampsia with severe features occurring up to 2 weeks after birth, medically indicated preterm birth before 35 weeks, placental abruption, fetal or neonatal death. There was also a primary safety outcome, and that was birth weight less than 10% for estimated gestational age. There were major secondary outcomes, both maternal and neonatal. For secondary maternal outcomes, there was a composite of maternal death with serious complications, and other secondary outcomes included worsening chronic hypertension, preeclampsia without severe features, mean clinic blood pressure levels, preterm birth less than 37 weeks, C-section, and blood transfusion. For secondary neonatal outcomes, there was a composite of serious neonatal complications, as well as NICU admission, hospital length of stay, birth weight less than 2,500 grams, hypoglycemia, bradycardia, hypotension, ponderal index, head circumference, and placental weight. So for this study, there was a final sample size approved, and I'm sorry, it's going back. You can't read it because it's double printed, but the recalculated sample size that was finally approved was 2404, which meant that there were 1,202 patients in each group. This was reduced from the originally planned enrollment of 4,700 patients, but this was still sufficient to detect a relative reduction of 33% in the incidence of the composite primary outcome events, with 85% power and two-sided alpha level of 0.05. This recalculated sample size did account for about 10% non-adherence to the trial regimen or crossover and 5% loss to follow-up. Just briefly about the statistical analyses, the primary analyses were performed as intention to treat. When the primary composite of birth weight outcomes were undetermined, multiple imputation methods were used from missing data. For regression models, there was multivariable log binomial and logistic regression methods that were used, and then adjusted risk ratios with 95% confidence intervals were calculated. Finally, they also determined the number of patients who would need to be treated to prevent one primary outcome event, and its 95% confidence interval. So from September 2015 through March 2021, a total of 29,772 patients underwent screening, and 2,419 women were subsequently randomized at 61 sites. More than 60% of the patients were excluded. More than 60% of the patients who were excluded. As you can see, there's a large number of patients who were excluded. More than 60% of them were excluded because they were either above the gestational age for enrollment or had history of known or suspected chronic hypertension, but failed to meet that blood pressure criteria for entry into the trial. This likely could have been attributed to the physiologic blood pressure drop that we see in early pregnancy. Ultimately, like I said, 2,419 patients were randomized, and in both arms total, 10 patients had immediate withdrawal and 1 patient withdrew after signing consents. Finally, there were in the active treatment group, 1,208 patients, and in the control group, 1,200 patients. So just briefly going through the results, this table shares the characteristics of the patients. As with a randomized controlled trial, the characteristics of patients were well balanced at baseline in the 2 groups. If you notice that in this table, in terms of race or ethnic group, non-Hispanic Black women made up 48% of the patient population, Hispanic women 20%, and non-Hispanic white women 28%. A majority, that is 56%, of patients in this trial had known chronic hypertension and were receiving medication. 22% had known chronic hypertension but were not receiving medication. And finally, 22% had newly diagnosed chronic hypertension. Labetalol and nifedipine were the most frequently used antihypertensive drugs before randomization. And just some other notable characteristics. 41% had gestational age of less than 14 weeks at randomization. And this is important to note because the findings of this trial were essentially then not confounded by patients having both chronic and gestational hypertension. What this largely suggests is that patients in this trial, because they were enrolled so early on, majority of them less than 14 weeks, that they had patients in this trial that were largely just chronic hypertensives, rather than conflicting that with, is this chronic or is this gestational hypertension? 16% of the patients had diabetes. And then the last line is about aspirin use. Notably, about less than 50% of the participants in each arm were using aspirin. So with respect to the primary outcome, that was a composite. Essentially, imputation analysis is for patients where there was missing data. And then there's complete case analyses. The results are the same in both evaluations. So in the complete case analysis, the primary outcome event occurred in 30.2% of the patients in the active treatment group and 37% patients in the control group. The risk ratio was 0.82, and this was statistically significant. This means overall that that active treatment to maintain blood pressures less than 140/90 was associated with 18% risk reduction compared to withholding treatment until blood pressures reached severe range. With respect to components of the primary outcome, preeclampsia with severe features occurred in 23.3% in the active treatment group and 29.1% in the control group. Medically indicated preterm birth before 35 weeks occurred in 12.2% in the active treatment group and 16.7% in the control group. The confidence intervals for these components did not cross 1, which means that these results were statistically significant. The number of patients who would need to be treated to prevent one primary outcome event was 14.7, so 15. And then lastly, oh no. Just going back briefly, at the bottom, for the safety outcome of the newborns with birth weight that was under the 10th percentile for gestational age was not different in mothers in the active treatment group versus mothers in the control group. And similar results were reported for newborns with birth weight under the 5th percentile for gestational age. Looking at secondary outcomes, specifically maternal secondary outcomes, this table describes the incidence of the maternal composite outcome that was low and did not differ substantially between the 2 groups. Severe maternal hypertension occurred in about 36.1% of patients in the active treatment group and 44% in the control group. So this was significantly different. And then finally, preeclampsia with or without severe features occurred in 24.4% in the active group and 31.1% in the control group. So again, significant. These were the only two significant differences. Looking at neonatal secondary outcomes, among these outcomes, preterm birth before 37 weeks was lower in the active treatment group. Low birth weight was also lower in the active treatment group. And these were the only statistically significant differences between the two groups. The frequencies of outcomes of severe neonatal complications and NICU admissions did not appear to be substantially different between the two groups. So for every landmark study, I create a slide similar to this one to summarize its key points. For CHAP trial, the conclusion that it came down to was that the strategy of targeting blood pressures to less than 140/90 in patients with mild chronic hypertension in pregnancy is associated with better pregnancy outcomes than strategy of just reserving treatment only for severe hypertension. And this too, without increasing the risk of small for gestational age at birth. Now, there are a couple of study strengths and limitations. One strength that I would highlight is that the trial population demonstrated diversity in age, race, ethnicity, and the results are generalizable to the US population of pregnant patients with chronic hypertension. And like I'd mentioned previously, because patients were enrolled early in the pregnancy, majority had a diagnosis of chronic hypertension and were already on therapy. Study results were not confounded by the inclusion of patients with both, chronic hypertension and gestational hypertension. One of the limitations that I mentioned previously was that the ratio of patients who were screened to those who were randomized was really high. A lot of patients were excluded, about 29,000 were screened and 27,000 were excluded. However, in the supplementary index data that was made available, the characteristics of the screened and the enrolled populations were ultimately similar. And like I said, more than 60% of patients were excluded were either above the gestational age criteria for enrollment, so more than 23 weeks, or had history of known or chronic suspected chronic hypertension, but had a blood pressure that was below the entry threshold. And like I said, this could have been probably attributed to the physiologic drop in blood pressure that we see during pregnancy. That could have contributed to this. One thing I would like to also note is that the CHAP study did not incorporate home blood pressure measurements into the study eligibility, which we know that most patients with chronic hypertension, we recommend that they monitor their blood pressures at home. And then we review those blood pressures to determine whether medication would be needed or not. In this trial, home blood pressure assessments were not utilized. So following the publication of the CHAP trial in New England Journal of Medicine in April of this year, both ACOG and SMFM released practice advisory statements with updated guidelines for management of chronic hypertension. So both organizations agreed that the trial clarified two previously unaddressed questions. First is, what is an evidence-based, safe, and appropriate blood pressure target in pregnant patients with mild chronic hypertension? And should antihypertensive therapy be continued or discontinued in patients entering pregnancy with chronic non-severe hypertension, mild chronic hypertension, that is. And so the results of this trial support the approach of recommending pharmacologic treatment for mild chronic hypertension, goal of less than 140/90, and continuing established antihypertensive therapy. So both organizations were in agreement. But there are still some important considerations and questions that remain unanswered by the CHAP study. So going back to the 2017 American College of Cardiology and American Heart Association hypertension clinical practice guidelines that lowered the threshold for diagnosis of stage 1 hypertension from 140/90 to 130/80. Now, there have been some observational and retrospective data in obstetric populations that has demonstrated an association between hypertension defined by, ACC and AHA and risk of preeclampsia and other adverse pregnancy outcomes, but future trials are needed in pregnant patients with mild chronic hypertension to investigate if treatment at a lower target blood pressure would confer further maternal and perinatal benefits or increased risks. And then also, given that the CHAP study excluded patients with secondary hypertension and other significant comorbidities such as cardiac or renal disease, evidence-based blood pressure targets in these high-risk pregnant patients remains undetermined. And then lastly, the CHAP trial only provided data on short-term maternal and neonatal outcomes. We need studies on long-term impact of antihypertensive therapy and maternal cardiovascular risk. Having said that, I wanted to briefly review the oral antihypertensive agents for treatment of chronic hypertension in pregnancy. These were the medications that were used in the trial with the exclusion of hydrochlorothiazide. In place, they did use amlodipine or allow the use of amlodipine if patients were already on it and if they preferred to be on it. But basically in the trial, the first line medications were labetalol and nifedipine. If labetalol was the first line medication used, it was started at a dose of 200 milligrams BID. Or if the patient was already on it, it was continued on that dose, and it was escalated in increments of 200 milligrams BID to achieve blood pressures less than 140/90. And that is again in the active treatment group. The maximum dose of labetalol was 2,400 milligrams per day, and that was prescribed as either 1,200 milligrams BID or 800 milligrams TID. And if the maximum tolerated dose of labetalol was reached, then nifedipine extended release was added. And however, if there was, if they reached the maximum dose of nifedipine extended release, or if nifedipine was contraindicated, then a third line agent such as methyldopa was initiated. If patients started on nifedipine, they were started they were started at 30 milligrams daily, and it was escalated in increments of 30 milligrams daily. Apologize, sorry. Sorry about that. So nifedipine was escalated in increments of 30 milligrams daily. And once that was reached to a maximum dose of 120 milligrams daily, then labetalol was started, as I mentioned previously, based on the protocol. Now, in terms of antenatal surveillance, these guidelines were published in 2019, and they haven't been impacted or changed by the results of the CHAP trial. Basically, for women who have chronic hypertension and are well controlled with medications, antenatal surveillance should begin at 32 weeks and should be continued weekly until delivery. If patient has poorly controlled chronic hypertension or other associated medical conditions, then antenatal surveillance is determined by the provider and usually started at the time of diagnosis and how it's continued, whether it's weekly or twice weekly, that's individualized based on patient characteristics and medical history. And lastly, these are the recommendations from ACOG for timing of delivery of patients with chronic hypertension. So if chronic hypertension is overall uncomplicated, isolated, well-controlled, either with or without medications, then timing of delivery should be between 38.0 and 39.6. If it is, if that's controlled, not requiring any medications. If it is controlled on medications, then you can deliver as early as 37.0 up until 39.6. And if it is difficult to control, if it's requiring frequent medication adjustments or multiple medications to control, then timing of delivery is earlier, 36.0 to 37.6. And with this, I don't have anything else in terms of any further updates in terms of management of chronic hypertension. So I'll be able to take any questions that anyone has. I know this was a little bit short, but I do appreciate all of you joining on with me tonight. My email address, if you can't see, it's written down there. I'm gupta8@bidmc.harvard.edu. Okay, so one of the questions that Dr. Naima Joseph asks is, do you think the recommendations can be extrapolated to patients on HCTZ? You know, like I mentioned, HCTZ was not a medication that was used in the trial. There are some concerns with HCTZ regarding electrolyte abnormalities, as well as a small for gestational age fetal growth restriction in pregnancy. So I think for that reason, this medication was not utilized in the trial. But if a patient is well controlled, these patients can be monitored during the pregnancy for fetal growth restriction. And I think the data can be extrapolated and the medication can be safely used overall, but I think based on the trial findings, people will likely switch these patients early on in the pregnancy to labetalol and nifedipine. And then another question, if these recommendations can be extrapolated to patients who are diagnosed with chronic hypertension based on newer definitions that I mentioned, greater than 130/80. I think that's definitely a possibility, but definitely there are going to be some trials. In speaking to personnel from MFMU network, there is some interest in combining the diagnosis of hypertension, lowering the diagnostic criteria for hypertension in pregnancy to 130/80, especially if there are maternal benefits, even in the long term for maternal cardiovascular risk. Most patients, like I said in the trial, they were already on medications for chronic hypertension. It is unclear whether they were diagnosed with chronic hypertension with the ACC-AHA criteria. And if that was the case, it's hard to, piece that out from the study data, but I suspect that that's probably the case. And so I think definitely these recommendations can be extrapolated, but we would need to validate that further in a future trial. Thank you so much, everyone, for joining. And again, I'd be happy to, there is someone who raised a hand. Are you able to share your question in the Q&A box? Oh, there we go. Dr. Lugata, your talking is permitted. Are you able to? You can unmute yourself. Oh, and these were my references. Labetalol in asthma patients is the question from Dr. John Lugata. So labetalol, one of the contraindications for labetalol is patients with bronchoconstrictive disease. Depends on how well their asthma is controlled. If patients are reporting exercise-induced asthma or remote history of asthma, or they're not using any medications for asthma, we do see patients using labetalol. However, these patients would likely benefit from nifedipine or starting them on nifedipine just to minimize that risk of bronchoconstrictive effect of labetalol. All right. And any other questions? Well, thank you so much for joining me. Have a good evening.